So good morning, everyone. First, I'd like to thank the committee for giving us the opportunity to discuss and present on our study on the value assessment for patients who underwent minimally invasive versus open colectomies at a tertiary medical center. It's a 10-year study. My name is Michael Abdelmasih. I'm a research fellow in the Department of Surgery at Marshall University School of Medicine in West Virginia. So we have nothing to disclose. It is estimated that more than 300,000 colectomies will be performed in USA in 2020 at an estimated average cost of $60,000 to $70,000 for non-complicated case. Nowadays, healthcare policies are assessing the value to determine schemes connecting reimbursement to performance. Our objectives were: one, to define a baseline value of colorectal procedures before the introduction of enhanced recovery after surgery protocols for all types of colorectal procedures, open and minimally invasive. Two, to determine variables that affect their cost. And three, to determine variables that predict complications. We developed a database of 81 predefined clinical variables, and these variables were standardized through the study period. We retrieved data from Marshall Warehouse retrospectively from January 2010 to July 2016, and prospectively from REDCAT from August 2016 to December 2019. Our studies were performed under IRB-approved protocols. We defined the value based on the equation value equal quality over cost, whereas the quality was assessed based on grading and recording complications using a standardized grading system for surgical complications. We gave the uncomplicated with no readmission cases a value unit of 1. For grade 1, the value was 0.95, grade 2, 0.75, grade 3, 0.6, grade 4, 0.5, and grade 5, we give that a 0 value, which represents death. Cost was defined as a total hospital charge for admission and readmission up to 30 days post-discharge, and it's corrected for inflation at a 5% APR. The unit value for uncomplicated robotic-assisted colectomy with no readmission and length of stay less than or equal 4 days was $68,048. We give that a value unit of 1. The statistical analysis were performed using MATLAB on 55 clinical variables. And for univariate and multivariate analysis, they were performed by linear and logistic regression as fitted. The statistical significance was set at 0.05 level. 426 patients were enrolled in this study. 10 patients were excluded from the cost and value analysis because of absence of submitted billing records. 14 patients were the outliers, which have the value outside the range of 3 plus or minus 3 standard deviation, and they were excluded. 13 mortalities were recorded, representing 3% of the total population of the study. Of the 426 patients, 55% were females. The mean age was 61. The mean BMI was 30. And the mean length of stay was 7.8 days, ranging between 10.8 in open emergency procedures to 5.4 in minimally invasive procedures. The mean readmission rate was 9%, ranging between 12% in open elective to 4% in robotic assisted. The mean cost was $106,295, and the mean value was 0.76, ranging between 0.83 in laparoscopic elective and 0.68 in open emergency. When comparing the types of complicated procedures by the year procedure, we didn't find any significant difference for all the types of procedures, the complicated types of procedures, between the retrospective and prospective data. Comparing the number of patients with postoperative complications by the type of procedure, we found the most of the complications in the emergency open colectomies, whereas the least were in robotic-assisted colectomies. For the value of colectomies by type of procedure, and for the cost of colectomies by type of procedure, the uncomplicated procedures we defined as those who were with no complications or grade 1 complications, which represents electrolyte imbalance. And we found that uncomplicated versus complicated procedures differed significantly in cost and value, but they didn't differ by type of procedure. In comparing the value of complicated open versus minimally invasive colectomies, and comparing the cost of complicated versus minimally invasive elective colectomies, we didn't see much of a difference. Using the univariate analysis, we find the variables that predict complications after colectomy to be for complications 1 and 2. They were age, diabetes, and type of procedures. Those were the significant ones. Complications of grades 3 and 4, we found the age, especially more than 65 years, diabetes, end-stage renal disease, ASA class, and surgeon. They were significant. And for complications of grade 5, which represents the mortality, we found the age, preoperative diagnosis, and type of surgery, urgent or emergency versus elective. For multivariate analysis, we found the variables that affect the cost after colectomy to be type of procedure, age, preoperative diagnosis, ASA class, diabetes, and end-stage renal disease, length of stay, and complications were significant. And for the variables that predict complications after colectomy, we found only type of procedure, age, pre-op diagnosis, ASA class, and diabetes. In conclusion, in our tertiary medical center, there was no significant difference in cost and value between elective type of colectomies, open or minimally invasive. Variables as type of procedure, age, pre-op diagnosis, ASA class, diabetes, end-stage renal disease, length of stay, complications, they were significantly affecting the cost of the procedures. As for complications, the significant factors were type of procedure, age, pre-op diagnosis, ASA class, and diabetes only. In the future, randomized controlled trials will be developed to decrease the rate of complications and improve value of colectomies in our healthcare system. Thank you.
Very good. Thank you, Michael. So unfortunately, our designated discussant for your paper, Dr. Gentile from Italy, has not been able to join us yet this morning. Dr. Stain has a question.
Well, thank you for a very good presentation. My question is about how you calculated cost. It looks from the abstract you used charges as a proxy for cost. Did you consider getting from your accounting department another method of cost, whether the cost of a robotic is the same as an open colectomy? In our study, we found that length of stay really influences what the cost actually is. Thank you.
Right. So thank you for that excellent question. And in order to eliminate the variables that affect the cost, like the length of stay, like what you said, we decided to calculate the cost based on the hospital charge for 30 days post-discharge. So for every procedure or length of stay in the hospital, any charge after 30 days will be included in the charge analysis.
So I have a question. Say, hey, Michael, Tim Pollock from Ohio State. Nice presentation. I enjoyed it. So I was going to follow up on Dr. Stain's question. One thing that we focus on is controlling costs. The other thing is trying to standardize costs. So the same operation in general should cost the same amount every time. In looking at your data, the standard errors and the error bars were very large. So there was a significant amount of variation in the cost per procedure. So my first question is, did you look to explain that variability? And then my second question, it follows on Dr. Stain's point, did you look at the different buckets? So perhaps it's more expensive to do the robotic case interoperatively, but you're saving money on the back end because of length of stay. So overall, the costs were similar, but did you specifically look at different buckets, if you will, of cost and expense associated with the operation?
Right, that's an excellent question as well. Thank you. We didn't see or analyze the different buckets of the cost, but what we did in order to validate the variables and the large interval, it's because we had this study for 10 years. So we tried to standardize what we had from 10 years by the inflation rate of 5%, which is not that accurate because it depends from year to year. But that's our way we try to standardize a cost with. But yeah, that's a good point to like break down the cost by these factors as well.
Greg Kennedy, off mute, please.
Yeah, Michael, really interesting presentation. I guess over that long time period, did you guys, have you implemented the ERP program, the Enhanced Recovery Program in your institution? And have you seen any changes there? You know, most of the data would suggest that most of these differences in cost and length of stay will go away under an Enhanced Recovery Program. But very nice presentation, very nice work.
Thank you. So our presentation or our study was done before implementing or before using the ERCP, and that was the purpose of the study, to compare between the protocols before and after. So our next step is to do the analysis of the procedures after using the protocols, the enhanced protocols.
Maybe the last question is, you might have mentioned it, I'm looking in the abstract, but do these include physician costs, or is this facility costs only?
These include physician costs and facility costs. That's hospital charge for the whole package.
Great, thank you.
Thank you.